So the TRUST study that I just presented here at ASCO is a study that examines the optimal timing of surgery in advanced ovarian cancer. There's basically two options, either upfront surgery followed by chemotherapy or 3 cycles of neoadjuvant chemotherapy, interval cytoreductive surgery, and subsequent chemotherapy. And we analyzed these two treatment strategies in a randomized fashion, 1-to-1, and found that in the overall population regarding progression-free survival, we could find a significant benefit for primary over interval cytoreductive surgery. However, in overall survival, this benefit was so diluted that there was no statistical significance anymore. When we analyzed specific subgroups of the patients, however, we found that especially patients with FIGO stage 3 disease do benefit from upfront surgery, as well as those patients with complete gross tumor resection. And this is indeed probably the most interesting finding because in contrast to previous studies that addressed the question, in the TRUST study, we put a lot of energy into surgical quality assurance. So participating centers had to qualify in order to participate in the study and had to have high resection rates, high surgical volume, and they were actually audited in their OR by a group of experts to see, to check on the surgical proficiency and also the infrastructure. And with this high selection for expert surgical centers, we'd actually achieve a very high rate of complete tumor resections, which is the most important aspect of surgery in advanced ovarian cancer. And just to give you an example, in the primary surgery group, the rate of complete gross resection was 70%, and the interval cytoreductive surgery was 85%. And so this was really cutting-edge, high-quality surgery that led to this excellent outcome of the patients. Yeah, this is something that everybody now needs to find in their specific centers. And I can tell you how we, in my center in the University of Munich, we interpret these results. And this is that if we have a patient with advanced ovarian cancer sitting in front of us that we consider potentially resectable and consider fit enough to undergo surgery, we do a surgical exploration in these patients. And if we find out that we can completely resect the tumor, even with ultra-radical surgical procedures, if we achieve complete gross resection, then we do it because we know, based on the TRUST data, that this improves their progression-free survival by 6 months and their overall survival by 12 months. However, if we cannot achieve complete gross resection, then we end the exploratory surgery there, give neoadjuvant chemotherapy, and then do an interval cytoreductive surgery, and hopefully then completely resect the tumor. And based on the TRUST data, even if it's best to have a complete resection up front, even in these patients that we cannot completely resect at the beginning, there is still a 50% chance that those patients can be completely resected at interval surgery. So it's a 2-step or 3-step procedure we currently do. I think personally for me, the most relevant takeaway is that if you look at the excellent progression-free and overall survival together with low morbidity and mortality and no detrimental effect on quality of life, short as well as long term, that radical surgery in the hand of qualified centers really makes a big difference, and that we should all try to get our patients operated in centers that really know what they do.